Nicholas Fabiano, welcome to the show. How you doing, brother?
Yeah, thank you for having me. I'm doing great.
Yeah, man. Glad to have made this work. You were you're in town, I guess, for an academic conference.
Yeah, I'm here for the American Psychiatric Association, the annual conference, and I'm just presenting a poster there, so it worked out perfectly.
Amazing, dude. Well, so cool. I'm excited to get into the topic of your expertise, the intersection of exercise and mental health, creatine and mental health, and then we're going to ultimately, I think, venture into your latest paper on ultra-processed foods and microplastics and stuff. All very exciting and important stuff. But let's dive right in. So exercise and mental health. Why do you think exercise is so important from a mental health standpoint?
Yeah, so I think, if you were to go all the way back, and I think fundamentally a lot of people know that exercise is something that's important for your health. You can notice those immediate benefits. And if you were to go way back, not even way back, 20 years ago sort of thing, and you were to look in the literature of exercise for mental health, and my expertise lies mostly in depression, people would laugh at you to say you could use this as a treatment for mental health. But it was something that I noticed anecdotally in working with patients, how much benefit you could have from exercise, either alone or with medications. But my own personal experience also led me there too. So when I was in my first year of medical school, it's kind of a little bit of a funny story where I was getting into the gym, and as gym bros do, we were arm wrestling each other. And what had happened was I actually fractured my humerus. You could probably see the scar here.
Oh my God, yeah.
Yeah, so I have a nice surgical scar from that. And after the surgery too, I actually sustained some nerve damage. So my wrist, I woke up with it essentially limp, couldn't use it. And I didn't know if it was going to come back. So for months and months, as I was rehabbing my arm itself, and even post-op, I was in the gym, curls, I couldn't even move my arm sort of thing. And I saw how much that impacted my own mental health when I was going through that, and how much it mattered to me before, because I've always been someone that was into soccer and different sports for that, and then really got into the gym. And then for that to all just be kind of taken away at once, I noticed that impact that it had. So from that previous knowledge, from what happened to me and how I noticed my own mental health improved as I was able to get more into stuff, I really wanted to make that a topic of not only my clinical work, but also the research that I was doing. So I started early on kind of looking into the space and looking, can exercise be used to treat depression? Because that made the most sense to me, because some of the other mental conditions that we treat, they're more of what we term like severe mental illness. And it can be harder to rationalize an intervention like exercise or these adjunctive measures for those treatments. So really got into the literature for depression, did a few studies, and here we are kind of now. And that's what kind of led me to that interest. And I've kind of spanned out from there, as you mentioned, with creatine and diet. And I really see all of these factors to be very fundamental to your health, because I think the current system, we see a patient with depression, you really only have two treatment options in simplistic sense. You have medications, you have therapy. And that doesn't really tackle the whole person itself. So I think it's important to really address all of those things. And full circle, being at the conference this year, the theme of it is actually lifestyle for mental health, whereas previous years it's more focused on the pharmacology and all of these different aspects. So yeah, I think it's been a great progression, and I'm happy to see my interests also align with maybe where the field is going.
Yeah, I love it. And what had you learned about the role of exercise and mental health at that point during your medical training? Yeah,
so at that point, it first started again anecdotally with just seeing patients and going a little bit off the script. It's always scary when you're a medical student or resident in your lower levels and telling patients to do things like exercise or stuff where your preceptor might say, hey, just prescribe them the antidepressant, just follow the algorithm sort of thing. So first clinically, I noticed like, hey, these people are getting better through these exercise interventions, but at the same time, we're also addressing their physical health. So we know that people that have depression, they have a lot of physical comorbidities. So whether that is high blood pressure, whether that is elevated body weight or things like that. And the exercise can help with that. And at the same time, they can benefit one another. So as I mentioned, getting into the literature more, I started to do some research and see, how does exercise compare to these medications? And there was a recent meta-analysis, which is when you bring studies together, describing or comparing exercise to some of these interventions. And I went over the study and I actually wrote a paper on it as well, correcting the notion, because it had came out and the media kind of took it up and said exercise is actually 1.5 times as effective as medications or therapy, which again, as an exercise advocate, great to hear, but it wasn't fully true. When you actually look into the data of this meta-analysis, it said that, at best, it's probably equivalent in antidepressant effects, which I think is still great, because when you have these treatment modalities, your job as a physician is to be able to educate people on what options they have. And I know as a patient, if I was sitting in their seat, I would love to have that as an option. And not saying that everyone should have to do that, but it's an avenue to kind of go down. So again, we wrote that paper kind of highlighting what exercise compares to antidepressants in therapy, correcting kind of the notion. And from there, kind of expanded from there and looked at other measures like the physical effects and such. So yeah, we kind of developed from there and kind of came to this position.
Well, also the population matters, right? Like 1.5 times as effective as medication might be true for a certain depressed population, but it's like to lump everybody who's depressed into, you know, an umbrella categorization. Like depression is not a monolith, and different grades of depression respond to medication more or less than others.
And that's a great point you make. So for the literature, most of it is based on mild to moderate depression. So someone with severe depression is someone that is, you know, totally bedbound, not able to function. People with mild to moderate still have significant impairment from their depression, but it's important to make that caveat because it can be hard for a patient to hear that, you know, just exercise. It can actually be very demeaning, and that is kind of the dichotomy in response that I've seen too. Lots of people are like, this is great. It's an awesome new treatment. But at the same time, inherent to depression is that lack of motivation, the lack of ability to kind of just go do stuff. And even if you want to, you just can't push yourself. So that's something to be aware of as a clinician, as a patient, when you're having that discussion with the patient, because it can come off the completely wrong way if you're talking to that patient and you make it seem that the lack thereof of exercise caused the depression, or that exercise is the only option for the treatment of depression. It's something that you have to be very careful in talking about because you want to see if that discussion is invited by the patient first, because they've probably had negative experiences with doctors before, maybe not even in the field of mental health, but you know, everyone has the scenario where you go to your primary care doctor and almost any ailment can get better from exercise, and you're met with, hey, go exercise, hey, go for a run, sort of thing. And it's not productive, and it can kind of leave a bad mark on that patient. So it's important as a psychiatrist, as a primary care doctor, when you're dealing with patients with depression, to see if that's something they want to talk about first before kind of forcing it on them. And I think that's important, and also stratifying, as you mentioned before, to the severity level. Maybe it's not appropriate to use in a severe depression, but that doesn't mean it can't be used ever. If you can get that person out of that severe depression and they want to engage in exercise, that's great. And then the other thing is too, it doesn't have to be used as a monotherapy. It can be used with other things too. So with therapy, with medications, it works better. So I think we get this notion where people operate in different camps. You're either lifestyle or you're either medications, but it actually works better together. So I think that's an important message to put out there, because it can be confusing for patients to think, I only have these avenues and I can't use them together. Whereas the reality is they can all be used together and it actually works better.
Do you remember there was a meta-analysis published a couple of months ago, or maybe it was even a year ago at this point, that found that dancing was counterintuitively more effective than pretty much every other lifestyle intervention in the treatment of depression?
Yeah, that was a meta-analysis, I believe in 2024 by Notel and colleagues in the BMJ. It's an interesting one. So in meta-analysis, you be very careful in how you interpret the effect sizes, because that meta-analysis similarly found that exercise was, you know, similar, but with the data point with dance, it almost was this outlier where you're saying like, what's going on? It's much better than the other ones. With that, my understanding was that data point was based on a very small study and a single study. And with that, you can kind of get these outlier data points. And what happens is in meta-analyses, the more studies that you get for a single data point, the smaller that confidence interval, and what I mean by that is the bars and your certainty of where that point lies become, but also the less of the outliers you have, because you have more of an average. And I wouldn't be surprised, not to say that dance isn't great, but just to make sure that we're communicating the evidence in a transparent way to the public as well too, that likely my suspicion would be if there was more studies on dance, you would see that number kind of come closer to running or weightlifting. It's just that the majority of studies are on running or weightlifting, whereas you have, you know, the one study on dance, which again, I think it's a great thing, but it's important that we look at that in the context of the evidence that we have, and also kind of are critical about it, because it's hard when you see that figure and there's that data point out there and it's very clearly an outlier, but that can be misleading to a patient that they say, hey, if I just go dance, everything will be okay. But you know, that might work for someone. But I think just making sure that we're clear on that point.
That makes perfect sense. And for my listeners, like the lay people in the audience, because I always encourage science literacy. I think it's crucially important. A confidence interval is like if it crosses 1, that increases the odds that it's basically a finding due to chance. Correct?
Yeah, and essentially, if your numbers that are included in that interval cross the what we call null value, then it's usually not significant. And for people listening to, the simplistic way of looking at that is looking at the p-value. If it's not significant sometimes, then that's a very wide confidence interval. Usually the number isn't significant. So what we like to see is that confidence interval to be very narrow, which means that we're very confident that the true value lies somewhere within there rather than it being wide. And how we accomplish that, again, is having more studies with rigorous design that really are similar to one another, because even if you have a lot of studies that are not so similar, you're going to kind of get data points everywhere because they're not measuring the same sort of thing. And even with lots of studies, you'll have a wide sort of interval. And that is an issue in the exercise literature, because you can imagine with antidepressant studies, you give someone a pill at X milligrams for X weeks. It's the same sort of thing. Whereas exercise, there's a lot of nuances to what that trial looks like, of what those people are doing, for how long, with a coach or not. And that's why sometimes in the exercise literature, you see a little bit wider of the intervals, because there's less studies, but they're also not all the same. So that's an important thing to note too.
Yeah, thank you for sharing that. So when it comes to exercise, I think you alluded to a few of the indirect ways in which it might help the brain. Maybe you can sort of reiterate those, but then I'd be very curious to know some of the more direct effects that exercise has on the brain, which I'm sure vary from exercise modality to exercise modality, cardio versus strength training, etc.
Yeah, so in terms of effects on the brain, and specifically from kind of this antidepressant mechanism, the big question is like, what is exercise doing directly to it? And I think it's helpful sometimes to break it down, actually. You know, the point you were alluding to is more of the biological side. I think it's important to break it down to actually biopsychosocial sort of formulation to kind of see what is it doing from all those avenues. So to talk about biological, there's a lot of different things that exercise does. But I think to reframe the discussion, we actually don't even know what causes depression. There is this serotonin hypothesis that says decreased levels of serotonin cause depression. And for a long time now, we know that that's not necessarily the case. There may be lower levels of serotonin in a depressive state, but it's not necessarily the cause. And I think although in the academic community that's well known, I don't know that that's well received yet in the general public, which is an important distinction to make. So that kind of leads into our discussion of what is exercise doing to the brain from the antidepressant effect of it. So we know there's a few things. One thing that I like to conceptualize for people is when you contract or use your muscles, traditionally we use them, we see them more as these kind of just muscles. They lift things, they do heavy things, you do all these different objects that you can pick up. But more recently, they're conceptualized as endocrine organs, where they release myokines, which is essentially a way for your muscles to communicate with your brain. So one of these myokines is something called brain-derived neurotrophic factor, or BDNF, and people often refer it as the miracle grow for the brain. So that's something that has a direct impact, and we know that can have some of those antidepressant effects. Other things that have direct brain changes too is different structures in the brain is actually larger. So the hippocampus, we know, is something with exercise actually increases in size. So that's an area that's important for memory. Other things too generally is exercise leads to a reduction in inflammation. So both peripherally, but also centrally. And there's many hypotheses for depression surrounded from that inflammation lens. So those are some of the biological mechanisms, and there's probably a lot more in the literature that you can get into, but some of the ones that are easy to kind of conceptualize.
Yeah, so BDNF, I just want to double click on that for a moment. There is literature that points to a depletion, I guess for lack of a better term, of BDNF in the brain of depressed patients, which also occurs in the brains of patients with Alzheimer's disease, which I'm not conflating the two, but that is interesting that exercise has been shown to boost this chemical that acts like this miracle grow protein, as you suggested. And
to that point too, we know that depression and prolonged episodes of depression is a risk factor for for dementia. So with that, it shows that these different stressors on the brain can have impacts that kind of intersect with one another and lead to downstream implications of such as dementia or such as these more chronic conditions that we see. They're all intertwined. And that's another point that I like to talk about a lot too, is depression is a single term. It's something that lots of people are diagnosed with. you're diagnosed based on having X number of symptoms that, have been arbitrarily defined. There's so many other symptoms that can fit into what a depression may be. People argue that, even pain could be a symptom. So whether it's physical or emotional pain, there's, depending on ways that you calculate it, 60 million ways plus to diagnose depression, but we put it under one single term. And I know this is a little bit of an aside, but I think it's important to talk about, because when we look at treating depression, and we have such little treatments right now, and we wonder why our treatments are so poor, it's because you're treating one entity, that's depression, when it's really 60 million different conditions, and you're expecting to have great outcomes with only a handful of treatments, exercise included, right? So it's not going to help everyone. But I think that's an important expectations and understanding for people to know that this one term that we have encompasses so much. And individual people know that. When you talk to one person with depression versus another, the cause, how it affects them, so different. Even beyond this mild, moderate, severe category, they're all so unique. So I think it's important to take into account.
The heterogeneity. Yeah, 100%. That, we see the same. In the field of Alzheimer's disease, you see the same thing. There are likely myriad causes, and the cause probably varies from individual to individual. Very helpful information.
Yeah, and I guess, sorry, to build onto the biopsychosocial thing that I didn't complete there, for exercise too, from the social side of it, something that we often don't give full effect is just exercising with other people. So whether you're going to the gym, whether you're in a fitness class, whether you're on a sports team, for some people, that might be the only socialization they get for the week or whatever's going on, and particularly in older individuals that, maybe their loved one has passed away, they're living alone. That's so important. We know the social connectedness alone, exercise even removed. But I think it's not a factor that we really take into account a lot, because a lot of the studies are based on exercise groups or based on with a coach or with a trainer. That's another person. That's an element of connection that is important for the exercise too. And then the psychological side too is more of, those immediate benefits. After you have a good gym session, you have that almost high. You feel that you can just tackle stuff and get over stuff, and you feel that momentum. And I think beyond the long-term antidepressant effects, that's also important too. That's how you kind of break the cycle, how you get into more exercise or different things. And looking through that lens, I think it's good to remove just the biological side, but also looking at the other elements where exercise might be helpful.
Can you speak more to the role of inflammation in depression? I know that there's the inflammatory cytokine model of depression. I've even seen some data suggesting that anti-inflammatory drugs, like NSAID drugs, can, in a certain subset of the depressed population, treat their symptoms. And then even SSRI drugs have these pleiotropic effects. They've long been shown to be, or known to have an anti-inflammatory effect.
Yeah. So right now, the inflammation hypothesis for depression and even bipolar disorder, because mood disorders in general, and for clarification, bipolar disorder is when you have these highs and lows. So people describe them as manic or hypomanic episodes, but more so they're predominantly depressive episodes. There's been a lot of literature to say, is inflammation a causative factor for these? And by that I mean, does inflammation cause the depression? Or is inflammation just a feature of it, where in a depressed state, whether peripherally or centrally, you have elevated levels of inflammation? It's hard to say. Right now, the literature isn't definitive in saying that this works or not. And what you alluded to as well too, there's trials looking at anti-inflammatory drugs for depressive symptoms or depression, usually as an adjunct to the antidepressants. And the results are conflicting. It shows that it works sometimes not, particularly in bipolar disorder, not as much. And it's traditionally more treatment resistant. And they've even tried to do subgroups of population where they take peripheral markers and say, who is the inflamed group, give them the anti-inflammatories. Some of those studies have shown that it works, some not. So I think there is a basis, and it goes back to the definition of depression. It seems to work in some people that perhaps there is more of that inflammatory predominant picture, but it doesn't seem to work in everyone, where it doesn't seem that it's this overarching treatment that will just cure all. But I do think that there's merit in looking into it more to see if there are subpopulations. And in the future, I would love to see this, because right now for psychiatry in general, even beyond depression, we diagnose conditions purely based on symptoms. So that would be akin to you going to the hospital, having chest pain, and they say you have chest pain. They don't say you have a heart attack. They don't say you have a clot in your lungs. You have chest pain. And we're going to treat you with this medication that we hope works. I would love for the future to say, I have these symptoms of depression. Let's do a test and see what kind of depression you have. Let's kind of get this into something more specific, and let's get a treatment that works specifically for you. Because again, it circles back to what I discussed, and why our treatment isn't perfect is because we're treating chest pain. We don't know what that chest pain is. We didn't diagnose it as a heart attack. We didn't diagnose it as, another medical condition. We're treating it at that symptom-based level, which I think we need to kind of get a better understanding of what's causing that, what's perpetuating that, and that way we can intervene more effectively.
Yeah. How do you, because I think sometimes like we run the risk of medicalizing natural human like emotions. Mm-hmm. So how does that, how do we stratify clinical medical grade depression as compared to, I occasionally get depressed and I don't feel like getting out of bed with the same vigor that I do on other days. How do we stratify the two sort of grades, I guess?
Yeah. And I think that's a great question, because I think you want to feel the highs and lows. If something bad happens, sometimes you want to feel low. It's part of being human, right? And you don't want to be on this, if you're to draw the mood spectrum of having highs and lows, you don't want to just be a straight line and not be able to feel happy and not be able to feel sad. There are times where you want to feel those emotions just to be human. So I think the defining factor is really speaking to the patient in front of you and talking like, how does this impact your day to day? Can you still function with how you're feeling? If the answer is yes, like it's hard, like in these days, maybe you can't get up, you can still go with that. You can, next day, I'm going to make up for the work I wasn't able to do, sort of thing. But if it's getting to the point where you're not able to do the things that you like, and you know that there's something almost just blocking that ability, I think that's where the conversation needs to be had with your provider, whether it's your psychiatrist, whether it's your primary care doctor, about, hey, this is impacting the life that I want to live, and I want to do something about it. So whether that's therapy, whether that's medications, whether that's exercise, whether that's modifying your diet, that's what your doctor should be there to do, be that resource for you. But the patient as well, too, we should let them have the autonomy to make that decision and say, hey, this is impacting my life. Now I want to intervene. Not, hey, I've been feeling sad today. I should start a medication or something. Because you're right. We don't want to over-medicalize stuff. We don't want to medicalize the human experience, because it's important just to be a human being.
Yeah. Do you think we have an overprescription problem in this country, or like where do you stand on that debate? Either these drugs are being overprescribed, or we actually need to broaden our diagnostic criteria and make sure that more people have access to them. I've heard divergent viewpoints when asking that question to other mental health care providers.
Yeah, my view on that would be this. I think we are, and to restructure that, is we're too focused on treatment and we're not focused enough on prevention. So I think right now, perhaps there is evidence to suggest that antidepressant prescriptions are increasing, particularly in younger populations. And it's hard to say, is that overprescribing due to increasing depression? Is that just due to kind of prescribing antidepressants for everything sort of thing? I think where we would see the most benefit, though, is in these population of people that are depressed. Yes, we need to focus on treatment and help them feel better, but it doesn't just stop there. It's not that once you're better, stuff is okay. We want to make sure that on both ends, you have the treatment population getting better. You have people that don't even have depression yet that could progress to developing depression. I think we need to focus more on the risk factors for relapse of depression and the risk factors for even developing depression. So not to say that these lifestyle factors like exercise, diet, and sleep are the sole causative factors for depression, but how I view it is that these are the fundamentals for your health, not even just mental health. So if you have someone that's in a depressed state, for instance, they're started on medications or therapy, they get better, and maybe they stay out of that depressed state for a few months or even a year or something great like that. But the underlying fundamentals of their diet, their exercise, and sleep remain unchanged. I think that your risk of developing depression later on is much higher. And we don't have a lot of data to look at these long-term studies to say, after we get someone to remission, then we optimize their lifestyle parameters. What's the risk of relapse? Because what you see a lot with depression is relapse. And a lot of the guidelines after times people have multiple episodes of relapse, they end up being on antidepressants for their whole life. And what I like and what I've heard from patients is that these lifestyle factors give you this locus of control. Whereas sometimes when you're prescribing medications, it's, I need this because I feel broken, which is not necessarily the notion, but that's how sometimes people feel. Whereas when you give someone an exercise prescription or talk to them about that, they feel like, I'm in control of me. Even if something bad happens, I feel like I can get out of this. And that's important too, because you want to have that internal sense of control over yourself, because it allows you to have better treatment outcomes. It allows you to engage in more things. So to your question, I think I had a long-winded answer, but I think perhaps there is a little bit overprescribing, but I think we're not focusing on prevention of these episodes and prevention of recurrence of these episodes once they do happen. We're too focused on treatment and these new fancy drugs with different mechanisms of action when you're tweaking just small receptors and things like this, when we know there are ways to reduce the risk of depression. And they're a lot simpler than all these different pharmacology and things. So I think that's the main point.
Yeah, no, I love that perspective. I mean, I had Dr. Judith Joseph on the show recently, who just wrote a book on what she calls high functioning depression, which I think is such a cool concept. But when I asked her that question, there was a bit of disagreement because, I can't help but look at figures like the fact that 1 in 4 women over the age of 40 is on some kind of antidepressant drug. And to me, it's like, very clear that there are people being prescribed not just those kinds of drugs, like that category of drugs, but other antibiotics. I mean, we talk about all the time, for example, that, that would be probably better served taking a more, holistic approach. But her perspective, which I respect, was that, actually, I don't see that. From my vantage point, we need to broaden access to these drugs so that more people essentially can get on them if need be.
Yeah, and I think my viewpoint for that is remembering our role as a physician is to inform the person in front of us of what the options are for treatment so that they can make an informed decision. So whether that patient chooses to have an antidepressant, whether they choose to do therapy, whether they choose to do exercise or diet, I think there is still that paternalistic culture in medicine in general, psychiatry included, where sometimes that we feel we know the best option for the person in front of us. But I think we need to remain in this humble position of saying we're educators for the person in front of us. That's what we went to school for, was to learn all these different things so that the patient in front of us can make that decision. So whether that's, as I mentioned, any of those options, we want to help facilitate that. And I think where there's a little bit of a disconnect is it's a lot easier for us to prescribe an antidepressant or refer someone to therapy, which again, therapy is hard too because there's not a lot of resources. It's very expensive for people. But there's not a lot of connection to the exercise, diet, sleep realm. Again, providers themselves aren't very comfortable speaking about those things, nor do we have a lot of resources to give to someone who wants to really get into it. So I think when we look at antidepressants and therapy, we have more streamlined ways to refer someone to that and get involved. Whereas our lifestyle ones, it's more of, again, go exercise, go do that, which they know that. The patient in front of you knows that. It can be condescending to hear, you should just go exercise. And I think that's why sometimes, especially in short form content, when I share stuff online for exercise and stuff, it can be taken poorly because it comes across as, well, just go exercise. But that's never the message. It's let's educate physicians starting from medical school to residency to being a staff on how to talk about this. And let's set up the system so that we can actually allow a patient to engage and be successful in some of these different things.
Yeah, I love it. When it comes to the types of exercise, is there a difference that you see in the literature, strength training, for example, versus aerobic style training? Or do they seem to be equally effective? What is the literature say?
Yeah, so honestly, based on the meta-analyses, we break up the exercise types broadly into aerobic, which is things like running, resistance, which is weightlifting, or mind-body, which is yoga or things like that. And across the meta-analyses, which is, again, bringing those studies together, they're pretty much similar. Not enough where there's a clear winner like the dance again, but there's not a clear winner in terms of what exercise is the best. The only general trend that we see beyond the type of exercise is the intensity. So we see that higher intensity generally is associated with greater antidepressant effect. A lot of caveats to that as well too, because the bias lies in people that are able to engage in more intense exercise maybe would be more prone to have a better response to that. And in older individuals too, we know that actually mild or moderate exercise may be more effective than very severe, because it can be harmful for someone's health to go that hard if you're older and older. So
I'll tell you, I'm very happy lifting weights. I'm miserable doing cardio.
Same.
So I don't know. But that's just my own N of one.
No. I completely agree. It's a great point you bring up, because I played soccer my whole life before and stuff. And then I tried to get into running and I was like, wow, I just hate this, because playing soccer was something that was less and less feasible as I got older, because the games are like, it's this men's league game at 10 p.m., 11 p.m. I want to sleep. And I didn't like the running and stuff. So that's the most important thing is talk to the person in front of you. What do they want to do? Not what is the best exercise prescription, is what do they want to do? Because the same thing with diet, you can prescribe someone this low calorie, high nutrition diet that tastes horrible. It takes hours to prepare. It's so much money to make. They're not going to do it. So the best diet or the best exercise is one that the person in front of you can sustain. And it doesn't have to be perfect, because particularly in depression, it can be overwhelming for someone to say, this is the goal I need to reach. I need to be working out for 1 hour every day at high intensity. You would look at that and say, I don't even want to start. There's no point. So starting low, going slow, and picking something that works for the person that they want to do. So if it's dance, they can dance. If it's they want to go to the gym, that's great. Go to the gym. If they want to start walking, that's amazing too. So working with your patient and not just having this prescription that says exercise or you need to run because this is the best, because there's no true best. The best is what you're able to do and sustain.
Love it. Okay, so we've talked about the types. We've talked about the intensity and how that might vary, according to demographic. But when it comes to dose regarding duration, is there anything specific there?
Yeah. So again, the literature is a little foggy there, but what we find is generally longer sessions, and again, not super long, where there's a ceiling to that. But between kind of like the 45 minutes to 60 minutes is where you see kind of more of the sweet spot of antidepressant benefits. But again, highlighting again that starting low, building up to there is great too, because what I like to highlight is when you look at the meta-analyses of these studies and you go from someone who's sedentary and not moving at all to even just a small amount of exercise, you see these exponential benefits from an antidepressant perspective, which begin to taper off over time and can even be too much exercise at some point. So I think it's really important to say, setting those goals low at the beginning, noting that that's actually where you're going to see the best benefit, but then getting to those optimal levels of, 45 minutes to an hour sort of thing. But whatever's sustainable for the person, maybe their job doesn't permit it. Maybe they have a bunch of kids at home they have to take care of. Any exercise is better than none. And that's always the thing that I like to get across to people, because some people get very fixated on, I need to do this or nothing, but anything is better than nothing. And that's really the main point.
Yeah.
There.
Yeah. Sometimes I go to I'll make my way over to the gym, but I'll park my car, I'll get up to the main floor, and I'll realize that I don't feel like working out. But then I'll just do the things, I'll throw out the plan that I had, and I'll just do the things that bring me the most joy. The exercise that I enjoy doing the most, maybe it's even just a little bit of walking on the treadmill. Because at the end of the day, I feel like even a shitty workout. I mean, there's really no such thing as a shitty workout, unless you're injuring yourself. That's a pretty shitty workout. But there's really no such thing as a shitty workout.
Yep.
Or a workout that's too short or anything like that.
Yeah, and that's the thing too. You might even notice when you have one of these days where you're like, I don't want to do this. There's no point. But once you start doing it, you're like, it's not too bad. And then you get into it and have a good workout. And that same principle can be applied to people that are experiencing depression, where it's like, hey, I don't know if I have the motivation to do it, but you just start really low and you build up from there and you're like, I can do it. It goes back to the locus of control, where you have the sense that this is me, I can do this, I can get over this. And it provides you with that increasing amount of motivation to do more, to have more intense exercise, and really build up from there, which is so important, because the point where you'll see people fall off or not want to engage is really the beginning, because that's the hardest thing, especially if it's for someone that doesn't have a background in exercise. It's something so new to them that can be so overwhelming. I remember when I first went to the gym, even from a weight training perspective, as someone who played soccer their whole life, and all these guys are just massive, and I'm like, okay, I don't know what I'm doing here. The same thing happens for your patient, right? You tell them to start running and they don't know what to do. You tell them to go to the gym and it's very overwhelming. I understand that, right? I've been there before too, and I think it's important to maintain that and to be able to talk to your patient about that, because otherwise you're just giving them a void prescription or talking to them about stuff, but it's not necessarily going to be actionable.
So much there. Yeah. Just greasing the wheels, I feel like is a phenomenal gateway into higher intensity stuff. Even on days when I the last thing I feel like doing is working out, just getting my heart rate up a little bit on the treadmill, just with some gentle walking. After that, I feel there's more that I feel like doing inevitably. And then when it comes to the gym environment, you brought up a really great point there as well. The gym is tends to be way more welcoming than I think people give it credit for. Like me personally, whenever anybody, I mean, this doesn't often happen, but whenever anybody's asked me for advice in the gym, like, you know, like somebody who's clearly like kind of a novice is like, hey, do you know how to like use this machine or whatever? Or what does this attachment do? Like, I love when people ask me for unsolicited, you know, advice in the gym, because it's like, first of all, it makes me feel good. It makes me feel like, hey, they must be asking me for a reason. You know, I must look like I'm doing something right. And I just love like, there's nothing that makes me feel better than helping somebody else on their fitness journey.
Yeah.
However small that you know, that the impact may be.
Yeah. And I think it's important too, because in depression, you have these automatic thoughts where people are judging me, I'm not enough. And that is heightened in these environments where, you know, even if you don't have depression, you're already feeling that way. But reinforcing that, you know, it's the same where all the gyms I've been to, where it's a very inclusive community. When you see someone that's clearly new, it's not like, haha, that person's starting off. It's like, that's great. Like, it's awesome to see that person starting that journey. And it's exciting even because at the beginning, that's when you see those major changes in your physical health, but also your mental health. So although you can feel that pressure, maybe being there with all these people that seem so experienced, etc., it's important, as you mentioned, to say that, you know, people are cheering you on there. They're not judging you, even though it may feel that way, which can be a major push away for a lot of people where they fear that evaluation. But it can also help too when you put yourself in that situation and you're so afraid of it from that anxiety perspective. That can almost be a way to help deal with that anxiety that's sometimes tied with the depression too. And it goes back to the biopsychosocial, the social part of exposing yourself to something that maybe was scary and realizing, hey, it's not so scary. And I actually like these people here and these are my friends, and it builds that social community. So it's so important beyond just the biological aspects, but just being in that community and feeling to be a part of it.
Amen. Yeah. And also I think it's important to underscore that you don't even need a gym membership. I mean, going back to the biopsychosocial model, like if you can't afford a gym membership, like this is not a therapeutic, you know, modality that is out of reach for you, because you can still, you know, likely go for a walk. There, you know, calisthenic exercise can be very effective, right? You
know, it's a great point. You can, whatever you like to do, you can adapt it for where you go. And I even follow that premise where, not when I fly places, but when I drive to rotations and I'm at a rural area where maybe there's not a gym or anything like that, I have this pull-up bar and 2 30-pound dumbbells, and put that in my car. And that's enough to do pretty much every workout. You can use the pull-up bar to do push-ups, pull-ups. You can orient it different ways. You have 2 dumbbells. You can do curls, lateral raises, whatever you need to do. You have enough weight to even do some leg exercise too, whether you're walking around. So obviously not super heavy if you're using them to curl, but it shows you how you can really bring this anywhere. And as you mentioned, even without equipment, with the calisthenics stuff, where you can focus on your core exercise and being able to stabilize yourself and different things like that, where again, a lot of people actually start off doing some of those things because they don't feel comfortable going to the gym, but it's something that you can continue on during your fitness journey because it's so easy to do and it's very accessible. Whereas even things like gym memberships can be expensive. Yeah. Having a trainer can be expensive. It can be hard to drive to the gym. It can be very time consuming to go there, get changed. Whereas maybe on a day where you're really busy, if you only have 15 minutes and you have something at home, that's awesome too.
Amen. Yeah, there have been so many times when I've been in like a random hotel room where I know that I'm not going to have time. I'm not in my hometown. I won't have access to a gym. I know that I've got like to give a talk and then I have to run to the airport and I'm going to be sitting and flying all day. But in the hotel room, you know, I'll do a circuit of isometric hold planks, for example, or wall sits and push-ups. And I mean, you could do a lot. If I'm traveling with a backpack, you know, and I want to do like weighted push-ups, I'll put my backpack on. And yeah, there's a lot that you can do by yourself without having access to a gym.
Yeah, you can really make it whatever you want. I think that's what's really nice about it. And it goes back to the whole locus of control. You can choose what you're doing that day. It's great to have a program or whatever you want, but you can really adapt it to how your day's going, how you're feeling. And you don't really have that personable factor with medications and stuff where you're fixing the dose or doing that, you take a steady dose of things, whereas exercise, you can really adapt it to what you want.
Yeah, so great. You could do rows. Like I've used my carry-on, like my Rolly carry-on thing. Like I'll like zip it up and I'll put like one hand on the desk of the hotel room and I'll do like rows with it. I look like an idiot doing it, I'm sure, but it works.
Yeah, and you can take out clothes, adjust the weights, what you need, and it works perfect.
There you go. I've even done like kettlebell swings with my backpack.
Yeah.
I mean, I look like a crazy person when I'm doing it for sure, but it's effective. It's effective and it costs me nothing.
Exactly, and it works.
Yeah, and it works. All right, let's switch gears a little bit and talk about creatine. Everybody's favorite supplement these days. Everybody these days is talking about creatine. It's really funny because I don't think many people know this, but I wrote my high school senior thesis on creatine. Oh, nice. So this was back in like the year 2000. So I was a very early adopter. But now I'm so thrilled to be seeing it get the credit that it deserves, not just from the standpoint of, physical performance, body composition, ergogenic goals, but also from the standpoint of cognitive health, of mental health. So what can you tell us about creatine?
Yeah, so as you mentioned, creatine is this supplement that is more traditionally seen to be used in the gym community, extended to runners as well too. It's this supplement that effectively allows your body to reuse energy more efficiently. How it works is you ingest creatine in varying doses, and we can kind of get into the nuances of that after, but it's stored mostly in your muscles as something that we call phosphocreatine. And what your body is able to do is it can kind of tap into those stores to regenerate what we call ATP, which is the energy currency of your body. So that allows you to get more reps at the gym. That allows you to get more miles when you're running, sort of thing. It just gives you more energy, and it allows for more progression from the fitness perspective. But as you alluded to, there's data to show that there are cognitive benefits to creatine too. So whether that's focus, whether that's your concentration, whether that's memory. And from there, it really went in more recently to the mental health side of things. So back actually in 2011, there was a trial by Lyo et al. In, I believe, 2011 in the American Journal of Psychiatry. And what they did was they combined creatine 5 grams with an antidepressant versus an antidepressant and placebo. And they wanted to see what happens from a depression perspective. What they found was that the creatine, as early as 2 weeks, had an improved antidepressant response, which is very important because antidepressant medications can take, sometimes 4 to 8 weeks to even have an effect. So for someone that's experiencing a debilitating depression, that's great news to hear, where we're already seeing a signal at 2 weeks. And then by the end of their trial, I believe at 8 weeks, there was still that improved antidepressant response. So that was kind of some of the early data. From there, there's been more and more trials combining it with antidepressants, which found very similar associations. And then more recently, just in 2025, there was a trial by Sherpa et al. In the European Neuropsychopharmacology, and they combined creatine with cognitive behavioral therapy, which is one of the most commonly used therapy for depression, anxiety. It helps you kind of rewire how you think about different things and gets you stuck in that depressed state. What they found was very similar to where creatine led to an improved antidepressant response after 8 weeks when they combined it with CBT. My thought behind that is maybe it allows you cognitively to engage more, get more out of therapy, but it was very promising to see that side of things. So since then, it's been very exciting, but one major gap that we found, and we've written a few papers on this, is creatine. It's been paired now with antidepressants. It's been paired now with therapy, but it's not paired with the thing that makes the most sense, exercise. That's where its roots lie in. And to circle back to the beginning of our conversation, we know that exercise has similar antidepressant effects to medications and therapy. So there's a literature gap there. We're working on a few trials right now to see, getting funding for that, to see if there is a benefit, because I think that's a major knowledge gap. But it's very exciting to see more and more trials. We recently wrote a paper describing more mechanistically what is maybe happening in the brain from a bioenergetic lens. And that led to more and more trials happening around the world. So I think in the coming years, if not months, we'll start to see more and more literature come out for creatine for depression, both as an adjunct to medications, therapy, or exercise. But I'm also excited to see perhaps even monotherapy for maybe mild depression. Monotherapy, I mean creatine alone, because creatine has such a beneficial risk-benefit ratio, and it's very cheap. So it makes a lot of sense. I don't have the data to support that yet as a monotherapy, but I think it's a question that warrants investigation. And it's very exciting to see. So that's kind of where the field is at right now. Most of it from the mental health lens is depression. There are some small single-arm trials in schizophrenia or PTSD, But I think over the years we'll see that continue to grow because the interest is certainly there. And whenever I write about creatine or anything online, people love to hear about the mechanism and what effects it may have in both the healthy population or people that may be experiencing a mental health condition. So very exciting stuff.
Super exciting. Now, the dose when it comes to creatine for physical physical performance boost, it tends to be, typically recommended that you take 5 grams a day. That's like the typical 3 to 5 grams a day is the typically recommended dose, with or without a loading period. And I think it's also worth stating that the performance boost that you get from creatine, it's pretty modest. I mean, it is significant, but it's, I believe I've heard it described as something like 5 to 10%, whereas like the rest of the gains that you'll see come from obviously training properly, nutrition and stuff like that. The big levers, sleep. But nonetheless, I mean, it's effective, it's safe. And around 5 grams seems to be the dose that it takes to saturate your muscles, right, with creatine. When it comes to the brain, like the brain health stuff, I'm seeing like way higher doses, anywhere from 10 to 20 grams a day for that. Why does the dose seem to be so much higher to derive a cognitive or mental health benefit as compared to what we would typically take for a performance boost?
Yeah, so that's a great question because as you mentioned, most of the creatine that we take goes to the muscle. So that's why you see the 3 to 5 grams sort of thing being kind of a staple for the fitness world. And right now we don't really have a clear mechanistic view of what's happening in the brain or what dose we need in terms of getting the brain benefits. We're starting to see early signals for perhaps around 10 grams per day. And this is something Darren Candow, he's a creatine expert in Canada, has spoken widely about. And I'm working with him on a few projects for creatine and mental health currently too.
He's been on the show in the past.
Oh, awesome.
If people want to look that up.
Yeah. So yeah, he's a great resource, the number one expert on creatine. But it's starting to seem like the benefits for brain-wise, so both cognitively, but also mental health wise, are maybe more around the 10 grams per day. And there's not a lot of studies to say mechanistically exactly what's happening or how creatine brain levels are changing because it's a lot more difficult to study. You need to use MRS or magnetic resonance spectroscopy to study that. And it's harder to put a lot of patients through imaging versus these clinical trials where you give someone creatine and measure cognitive effects or measure antidepressant effects.
It's probably that your muscles preferentially take it up.
Yeah, that's the thing.
Because your muscles are way more important from a survival standpoint as compared to your brain.
Yeah. So we guesstimate that about 95% of creatine goes to your muscles. And that's because there's more transporters that are expressed there, whereas the brain has a lot less. And again, the thought is that when we talk about creatine for muscles, we talk about the span of weeks of having an effect or saturation. But for the brain, we don't really know yet, but we're thinking that it might be longer periods of time needed and higher doses to really saturate the brain creatine levels. And by extension, some of the cognitive and mental health benefits. And again, it's really hard to say because we have a very brain-centric view of cognition and mental health, which makes sense in one arm. But we also make a lot of assumptions that the brain benefits are exclusively causing the cognitive benefits or the antidepressant benefits, whereas perhaps the muscles and the communication with the brain mediate some of that too. So I think we'll see more literature come out mechanistically what's happening and what dose we need, but the early signal is seeming to see around 10 grams. But to speak to your other point about the higher doses, there have been these smaller studies that look at single doses sometimes of high doses of creatine. So there was one that came out, I believe it was this year, where they took sleep-deprived people, which is a state of metabolic demand, similar to something like depression. And what they did was they gave them 0.35 grams per kilogram of creatine, which is a pretty hefty dose. And what they found was after that single dose, they had benefits to their cognition, but also brain metabolism after being sleep-deprived. So we're seeing signals for that. I don't know how sustainable some of these higher doses are, but around 5 to 10 seems safer. But I'm sure we'll get more data for these higher doses and maybe even higher in the future because we don't really know from the brain perspective as much as we know about the muscle.
So interesting. Yeah. So just to synthesize what you just said so that I understand it, creatine is typically thought of as like this long game, right? Where you take it for 28 days to a month, you want to saturate your muscles. The effects are not ever really thought of as acute. Like they're effects, benefits that are derived over chronic use of creatine. Similarly with like the cognitive benefit, but there has been signal that very high dose can actually have an acute effect in the setting specifically, I guess, of sleep deprivation.
And that's kind of where the question mark lies, is how do we optimize creatine intake into the brain? Is it these high doses where you saturate the muscles and the rest goes to the brain? Is it a prolonged period of time of a higher dose to allow that brain to get more creatine? And right now we don't have a definitive answer where we can say this is the thing that works best. But it seems that higher doses for longer periods of time is where that may lie, which is why some of the trials that we're setting up right now are structured around that, of having higher doses. And even personally for myself, I started taking 10 grams a day as I started writing some of these things, whereas I had been taking about 5 grams from more of the fitness perspective for almost a decade. And when I started looking into the literature, I was saying, if I'm recommending some of these things, or if I am seeing some of these benefits, I should try this as well too. And it's hard to say in an N of 1 being myself if I've noticed significant benefits just because of the creatine. But I want to say after being on a call shift where I work 24 hours overnight, I get very minimal sleep. I feel that I'm able to function a little bit better the next day. Again, that's one person, not going to work for everyone. But I think there is value in if you're looking into this in a substance that has that risk-benefit favorable ratio, seeing what effects it has on me, plus the studies as well too. So
do you take all 10 grams in one go?
So no, what I do is I take monohydrate first, which is a lot of people have questions around that, but I take monohydrate and I split the dose. I split it 5 in the morning and then 5 at night. I'm not typically someone that gets a lot of stomach upset, but people find that if they take all 10 grams at once, they can feel a little bit more bloated. They can have some stomach distress. So I thought just to avoid that, I'll take 5 in the morning, 5 at night sort of thing. Which has worked well for me so far. And again, just using the monohydrate because the studies so far, almost all of them have used monohydrate, which is just creatine bound to water, essentially. Whereas there are other forms, they're a little bit more expensive, and there's not a lot of literature backing those ones. Although they're probably the same, I like to stick as much to the evidence as I can, just to avoid any substitutions or any effects that may change because of that.
Same, yeah. It's also the cheapest, most widely available, creatine monohydrate. When it comes to this sleep deprivation study, I'm not sure that you mentioned like what the dose ended up coming out to. Was it about 20 grams or?
Yeah. So this is interesting. So most of the studies work on a fixed dose. So 5 grams, 10 grams, 20 grams, etc. This was 0.35 grams per kilogram. So for your typical 160 pound person, that's probably about 26 grams.
26 grams?
26 grams.
Wow.
So it's a big dose. And as the weight goes up, the dose goes up sort of thing. So it's a hefty dose. It's a single dose. That's the point that I like to make. But I think it's interesting because these are the studies where you start to see a signal for more research, not necessarily a definitive answer, but you're starting to see, okay, with a single dose in a metabolically demanding state, we're seeing acute benefits. How can this be adapted both long-term? How can this be adapted at lower or higher doses? Because maybe that was too high. Maybe that was too low. We don't have enough data points to really say, but I think it's a very interesting signal to say we need more research on either ends of the dose, but also the length of therapy being a single dose versus repeated. And then also safety data for the higher dose studies, because most of the literature around creatine is around the 5 to 10 gram dose range, which says it's relatively safe in a general sense. But to say 30 grams and et cetera I can't say that with certainty right now. So I think we need a lot of literature to say long-term kind of what's happening from that perspective, but it's interesting to see some of these trials come out.
Yeah. For people that take creatine, don't you tend to see like an uptick in creatinine levels on labs?
Yeah, so that's something to be aware about, especially in patients that may have regular labs looking at their kidney function because of medications they're on, because some physicians actually aren't aware of that because taking creatine, the creatinine level can artificially rise. And just to explain that concept is sometimes when you're having kidney dysfunction, so whether you're dehydrated and your kidney's not being perfused enough, you can see acute bumps in your creatinine, which can indicate something called an acute kidney injury. Usually if that's caused by dehydration, you just rehydrate, whether that's by drinking or IV fluids. But with creatine, you might see a bump in the creatinine because of the creatine itself. This is where alarm bells come up and lots of people ask about kidney health, et cetera, because you can have these bumps, which doesn't necessarily signify kidney damage, but it's something to be aware of in that sense where if you're speaking to your doctor, letting them know that you're on creatine because it can, again, cause those artificial bumps, but it's not necessarily indicative of damage to your kidney. Again, at those lower ranges, not at the higher ranges, I can't speak to that point. But just to be aware of, otherwise it can lead to medical investigations and all this whole thing where it's just creatine that you're taking.
Yeah.
To avoid that whole circular sort of picture from happening.
Yeah. Thank you for clarifying that. Okay. So let's shift gears yet again. I do want to talk about this paper that you sent me before you came into studio, looking at the potential impact of ultra processed foods on depression. And in that paper, you also talked about the potential threat to our brains posed by exposure to micro and nanoplastics, which I thought was a fascinating connection to make, not one that I had previously considered. So yeah, what can you tell us about those connections?
Yeah, so just a little bit of a background for that. So a few months ago, a paper came out in Nature Medicine looking at people, their brains and microplastic accumulation, and they found a significant amount of microplastics in their brain. What was interesting about this study, though, was this was the first study to really link it to what I would say more of a neurological or mental health lens, where they looked at people's brains with dementia as well, too. And they found that people with dementia had higher levels of microplastics. With that, it's not saying that that's necessarily causative, because we know that with Alzheimer's disease and different dementias, the blood-brain barrier can become a little bit more leaky, perhaps allowing more microplastics to come in as a result of the dementia rather than microplastics causing. But I thought it was an interesting paper because it really painted this interesting picture of, we're seeing microplastics now in our brain. We see it in a lot of other organs too. What effect does that have on other things? So to bring to the current paper that we were discussing is, with this Nature Medicine paper showing that microplastics accumulated in the brain, we know that, as I mentioned, a significant source of microplastics can be something like ultra-processed foods. There's a large body of literature to suggest that ultra-processed foods are, on a population level, associated with adverse mental health outcomes. So depression, anxiety, other disorders, and even from a randomized control trial lens, we know that when you take people that have high ultra-processed foods in their diet, you give them either dietary advice or directly change their diet, in a few weeks, you actually see significant improvements in the depression. And one of the first trials looking at that was the SMILES trial. So this paper that I had written was kind of putting all these ideas together. And again, it's a viewpoint. We don't have the data to say necessarily microplastics are causing depression or anxiety. It's a very hard topic to study. But again, ultra-processed foods being a significant exposure source for microplastics, and knowing that this exposure source of ultra-processed foods can be associated with depression and anxiety, what we had written about was that perhaps microplastics could be mediating this connection. We know that ultra-processed foods and microplastics in the brain have similar mechanisms of the adversities that they cause, whether it's inflammation or cytokine changes, all of these different things. They overlap a lot, and perhaps that's because maybe this is a core feature of some of the ultra-processed foods, because during the packaging process, what they're stored in, they introduce a lot of microplastics. So the thought was, we should really look into this association, because if we know that ultra-processed foods are associated with all these adverse mental health outcomes, perhaps we can minimize this by minimizing the microplastics. So it's a very difficult topic to study, because you can't really expose someone ethically to X amount of microplastics, see what their mental health outcomes are. And the same thing is with removing microplastics from their food. You can't knowingly expose someone to higher amounts and then see mental health outcomes, which is why in this paper, what we posited was perhaps it would be helpful to have something like a dietary microplastic index. So similar to a dietary inflammatory index, where different foods are scored with different inflammatory measures, there can be different foods that have different microplastic index. That way you can use population data to look at these health surveys of what people are eating, guesstimating what the microplastics are, associating it with some of these adverse mental health outcomes or dementia or different things like this. And then on a population level, we can have strong ties between ultra-processed foods mediated by microplastics and adverse health outcomes, because the literature so far is very scarce. We know likely microplastics are bad to be in your brain, but we don't know a lot of the downstream health consequences, specifically in the mental health realm. So that's a big area of gap in the research, and there's not an easy way to study it. So that was kind of why we put that paper out, was to really put an idea out connecting ultra-processed foods, microplastics, and some of these adverse mental health outcomes that we know exist.
I feel like I have this like weird sense that even saying that we know microplastics are not doing good things in the brain would be a controversial statement to make on social media today. You know that there's gonna be some food scientist that comes out of the work ready to gaslight you. It's fine. But no, I mean, like it's terrifying. We're just inundated with exposure to these compounds, microplastics, nanoplastics. What do we at this point know? What types of ultra processed foods are the most nefarious from an exposure standpoint?
Yeah, it's hard because right now we don't have great classification of which ultra processed foods have the highest amount of microplastics, and that circles back to the discussion I mentioned about the dietary microplastic index. If we could make this database or association between different foods, how they're prepared, and what level of microplastic that food may contain, then we could then use that data to associate it with the adverse outcomes. But we don't necessarily have a great grasp on that now. The general sense is that during the processing and packaging procedures, that's where a lot of the microplastics are introduced. So in that same notion, foods that are more heavily processed on the ultra processed sort of lens or are more packaged in plastic packaging probably have higher amounts of microplastics, but we don't have a great breakdown to say this is the ultra processed food to avoid the most. And my recommendation always is when we don't really know, but we assume that there may be adverse health consequences, trying to kind of avoid those to the best we can, but with the acknowledgement that we can't really avoid that in today's day. Ultra processed food, but also microplastics, because they're everywhere. You would drive yourself crazy trying to have a zero microplastic approach, but there are things that you can do to really minimize that.
Yeah. And what did you find specifically about the amount of microplastics in chicken nuggets?
Yeah, with chicken nuggets. So in previous literature, they compared chicken nuggets to chicken breasts, so both chicken, and they found that the microplastic content of chicken nuggets had about 30 times the amount. So a significant exposure. In the previous paper that we also wrote too, we made recommendations about how to reduce your exposure to microplastics, because a very common question that people ask me is, if these microplastics are in my brain, how do I get it out? Makes sense, right? Because this Nature Medicine study found that there was about a spoon's worth of microplastics in your brain. So people logically are saying, how do I get this out?
A spoon?
A spoon's worth, yeah.
Teaspoon or tablespoon?
Tablespoon.
Tablespoon?
Yeah, it's a good amount of microplastics in the brain.
Oh my God.
So people logically are saying, how do I get this out? And right now we don't have a lot of literature to say exactly how. But to get into the nuances of the Nature Medicine paper, what they did was they looked at microplastics in people's brain. They also did sub-analysis by how old they were, and they didn't find a significant accumulation based on age, because you would imagine that someone who's older would have more significant exposure to the microplastics and thereby have higher levels, but there wasn't, which is a reassuring finding, because to me that shows that the body has ways of clearing that. And with that, that's where I think at terms of where the evidence is now, we should focus a lot of our efforts is minimizing the amount of plastic exposure that we have. So we had made a few recommendations from that end. So we spoke about water bottles can be a significant source of microplastics. Different foods like ultra-processed foods, seafood, canned foods, that could be a significant source. But another significant source of microplastics can also be how you store your foods. So storing it in plastics, and particularly warming it up in plastics, can be a very significant exposure source. So avoiding some of these things is probably where you'll get more bang for your buck than trying to remove it from your body, because right now we don't have easily accessible nor heavily evidence-based strategies to especially remove it from your brain.
Yeah.
So that was kind of the advice that we had made in that paper in terms of how to minimize your exposure rather than focusing on removing it from your brain. Again, based on the Nature Medicine study that said, based on years alive, there wasn't really an association based on the exposure. So again, hinting at that the body can remove it in different ways, and we don't entirely know how.
Well, what do you say to those that believe that just raising awareness about this is inherently fear-mongering or alarmist?
Yeah, I think it's important it goes down to the role as a physician is making sure that people are aware of things. So personally, for myself, I would want to know about things even before the data is necessarily definitive. We don't know what these long-term health consequences are. We don't know if it's going to cause depression. We don't know if it's going to cause dementia. We don't know if it's going to cause a lot of these physical ailments too. But logically, if you have that significant amount of plastic in your brain, I think that there is something that we should do to minimize that until we get the data, because who knows when we have the association for heart attacks, for all these different conditions that I mentioned before. But I think in the interim, there is a rule to say that let's minimize our exposure to minimize the chance of potential risks that we don't even frankly know would exist. And I think communicating that fact to the patient is important. And if they say, hey, I don't know any risks over here, I'm going to keep drinking my water bottles, and that's okay. But I think, again, our role as a physician is to make sure that we're educating people and taking that lens rather than saying, there's not definitive links here and here. Let's just not worry yet until it gets really bad. But I think taking more of a proactive approach.
Yeah. Is this what's sometimes referred to as the precautionary principle?
I think so, yes.
Yeah, it makes a lot of sense. I think awareness is so important. And I shudder to think of anybody out there, particularly somebody who's actually educated, who's actually educated on these topics, wanting to withhold this kind of information from the public at large.
Yeah, and that's why I think sometimes in our academic circles, we're so fixated on having this absolute value before informing the public about things. And sometimes even when things are on guidelines and stuff, we assume that trickles down into action in the public. But that's not always the reality, especially in today's day and age with the power of social media and being able to speak with people more directly. I think it's very important to use that in a way that can benefit people and can inform people, not necessarily from a fear-mongering lens, but from an informative lens and an actionable lens to say, hey, this is what you can do to maybe minimize it. Not selling anything. It's saying don't use water bottles, don't use these things. Until we can really say, what does the evidence show?
What would you say are the biggest takeaways from your work that you want my listeners to, implement in their lives?
I would say that the biggest thing is with mental health in general, the fundamentals to remember are exercise, diet, sleep. There's a lot of different treatment modalities that we have for mental disorders such as depression. But I think really focusing on those fundamentals is where you'll see the best success. You'll be able to remain out of that depressive episode and even prevent depressive episodes from ever occurring. So I think that's the biggest principle. And for something like creatine, I think the evidence is very still preliminary. But again, the major point is that the risk-benefit ratio is so favorable that it's something that, of course, you want to talk to your doctor about before starting, but it has such a beneficial profile that it's beneficial to at least give a try, whether it's for a physical health aspect or whether it's depression. It may help, and speaking to your doctor about something like that. And then from the microplastic lens as well too, there's a big question mark of what exactly is with that doing, but we know that there are levels accumulating in the brain, and perhaps minimizing that is the best approach. So I think a long-winded way to say those three different things, but yeah, I think that's the summary that I'd like to let people know.
Yeah, I love it. And what does the landscape look like for you in terms of your future research?
Yeah, so right now I'm still in my third year of residency, so I still have to finish my last 2 years, but I'm planning on doing my master's and likely a PhD after that. But my future research, I really want to focus on the lifestyle domain, so exercise, diet, sleep. With that groups into the creatine, like I mentioned, trying to set up a few trials around there, but really making this a fundamental aspect in mental health rather than just this adjunct. In the future, I would love for this to be something that's first recommended to patients in all the guidelines to make sure that everyone's really getting that. And again, beyond depression, most of the episode has been on depression, but I'd love to see this for schizophrenia, for bipolar disorder, all these different things where we know that people are at such a high risk for physical health disorders too. So I think the overarching theme is this, but my grand scheme of things is removing the divide between mind and body, which we've drawn and which has led to a lot of this dysfunction that we've seen in medicine. So a few goals, but that's kind of the general premise of what I'd like to see.
Yeah, clearly an underachiever. Very exciting. And where are you born and raised?
So I was born and raised in Thunder Bay, Ontario. So it's a smaller city in Ontario. I went to medical school in Ottawa, and I've stayed there since. So I like it there. Probably stay there. But
so
yeah.
Cool. Dude, you're killing it.
Thank you.
Yeah. Congrats, man. So cool. Well, I've got one last question for you. Thank you for coming in.
Yeah, thank you for having me.
Yeah, and it's also great to get to know you in person because I've followed you on Twitter for some time. You always post these great threads, very informative and always like broken down, easily understood for lay audiences. So thank you for your science communication work as well as your work at the bench, as they say. Very impactful stuff. But where can listeners find you on social media? How can they support your work?
Yeah, so as you mentioned, I'm mostly active on Twitter or X where I post these scientific threads. I'm starting to post more on Instagram as well too. I have a YouTube as well. The same @ is for all of them, so it's NT Fabiano, Fabiano. But I would say the most bang for your buck would be on Twitter. I just write about different studies there. It's a great way if you want to interact with me, ask me questions about the study too. I try my best to respond to most people. But yeah.
Love it, brother. Well, last question that gets asked everybody on the show. What does living a genius life mean to you?
I think living a genius life means just optimizing the fundamentals of your life. So as I mentioned, making sure that you're optimizing your exercise, diet, and sleep with what works for you, because that lets you be the best you. You're able to engage in different things that you want to do and really aspire for your goals. So I think it's really focusing on the fundamentals. And when I say the word optimize, that doesn't mean make things perfect. It means make it perfect for you. And that would be the message I'd want to provide to everyone.
Beautifully put. Well, thank you, Nicholas.
Mm-hmm. Thank you for having me.
Yeah, of course. Thank you guys for listening. Share this episode with people in your life that may benefit from it, and I will catch you on the next episode. Peace.
Hey, if you liked that video, you need to check out this one here, and I'll see you there.